Good morning and good afternoon, everyone, and welcome to this session today. I hope you're all keeping well, and it is my great pleasure to introduce today Mr. Dominic Thompson from our neurosurgery department at Gosh. Dominic has trained in London, but he also was in Paris, Chicago, California. I hope you're all sorry, and has been a consultant at Gosh since 1998. His special interests are spinal dysraphisms, craniovertebral anomalies, and also moya-moya disease. And today he will be talking about the craniocervical junction, a talk which he had initially offered to do in spring of this year. And I had hoped that we could have it online, on site with everyone around. But here we are now online, and we actually have a lot of people joining in. So welcome to everybody. And without further ado, I would like to hand over to Dominic. Thank you.
Uli, thank you very much indeed, and I'd echo your welcome to everyone. I mean, what started off as an invitation to give a talk to a few radiologists at Great Ormond Street seems to have expanded a little bit, so I'll do my best, hopefully, to provide something for everyone and give, I guess, what will be a personal view on the craniovertebral junction. What I aim to try and do in this is to really try and hopefully ultimately simplify the craniovertebral junction. It's an area that causes massive confusion. I think it's often a cause of a lot of debate amongst neurosurgeons, radiologists, and so forth. So I'm going to hopefully try and simplify that. I want to demonstrate how you view the CVJ depends really very much where you're coming from. Of course, it's very important then that we try and develop both strategy and tactics. And there are differences in those two things. I mean, our strategy is really the way we're going to analyze the problem. Our tactic is then, that's really back down to the surgeon, how then you're going to execute a management strategy, a management tactic, if you like, then to overcome those problems. And you'll see there I've included a painting here that I really like. This is Frida Kahlo from Mexico. She actually suffered spinal trauma when she was younger. And this, I think, beautifully depicts the pain, the restriction and claustrophobia associated with spinal injury. And you can see all the nails there indicative of the neuropathic pain. As I said to you a moment ago, one of the problems with the CVJ is the sheer spectrum of abnormalities that can have a craniovertebral junction problem associated with them. And as I said, in a way, as neuroradiologists, as surgeons, as doctors, it's impossible to know everything about every one of these conditions. And this is just a small smattering of the ones that I've seen over the past few years. And as I say, how you look and analyze, how you do your strategy for these various cases very much depends on the perspective from which you are looking at it. If, for example, you are a metabolic physician, then you will subgroup these conditions in a different way. I mean, we know, particularly, for example, with the storage disorders, the mucopolysaccharidoses, we have a strategy and tactic for those. But these are very different in the way they behave, for example, to the collagen disorders. This, for example, is Morquio syndrome, and you can see a very typical example of the body habitus, and also the very typical problem that they get. In addition to this diffuse skeletal dysplasia of platyspondyly, they're very susceptible to compression, stenosis, and damage at the craniovertebral junction. And in fact, this is some work that we published a couple of years ago based on our experience. And you'll see that actually in the Morquio child, they have a very high risk of progressing to craniovertebral disorders and needing surgery. That, for example, would be very different to, say, a child with Down syndrome. And so a metabolic perspective can be useful because it gives you an idea, or it can give you an idea of natural history. Another way that addressing this from a metabolic point of view can be useful is it can alter, many of these conditions now, there are disease-altering drugs that will influence the outcome. I just mentioned mucopolysaccharidosis, and as now there is now enzyme replacement therapy available for those. This is osteogenesis imperfecta, and you can see in this study how the use of bisphosphonates was able to push back the time scale over which craniovertebral problems developed in these children. In osteogenesis imperfecta, they're particularly susceptible to this problem of basilar invagination, but as I say, strengthening the bone can delay progression of the basilar invagination over time. Sometimes also it tells you a little bit about the disease. This is an interesting condition. This is juvenile intervertebral disc calcification. This was a 12-year-old lad I looked at. You know, if you saw an abnormality like this in an adult, yeah, you would think of a fixed structural problem that needed immediate surgery. Whereas in the child, this is thought to have an underlying inflammatory problem. And in fact, the management of this is conservative. And you can see quite dramatically how just with immobilization, 2 months later, this problem completely resolved itself. So the metabolic perspective can be a useful one. But of course, there are others. What if you are a geneticist? If you're a geneticist, you're going to stratify and classify these conditions in a different way, because now there's a wide range of genetic mutations known to explain some of these. You know, we'll all be familiar with, for example, the FGFRs in the craniosynostoses, many of which have a craniovertebral abnormality. I mentioned already the collagen disorders, particularly the COL2 mutations. Again, they have a very different phenotype and different implications for the craniovertebral junction. And of course, knowledge of the underlying genetic abnormality can be very useful in terms of patient and particularly parental counseling for the future risk. But in fact, the genetics is much more complicated than just knowing what the gene is. Because whilst some of these look as if they may be single gene disorders, many of them we never actually have a genetic explanation for. And indeed, even where there is a gene, the expression of that gene can be very much changed by epigenetic factors. I've just put in here gestational hypoxia, DNA methylation, and so forth. But there are also a number of environmental factors that can interact with an apparent genetic predisposition. And I've put here things like alcohol, maternal diabetes, various drugs can also give rise to the segmentation anomalies, which I've used as an example here. So again, genetics definitely progressed. It's definitely going to help us. But actually, does it actually help you as a clinician, as a radiologist or a surgeon in making a decision about management? In most times, it doesn't. So what are other ways of looking at it? If you're a developmental biologist, again, you'll have a third way of looking at this group of conditions. You know, there's particularly animal models now. There is some good work done on the way the spine segments, and some of these various anomalies have been attributed to specific errors at various times in early development. As you'll know from, if you look at overall spine development, initially the mesoderm forms after gastrulation. We then get segmentation of that mesoderm to produce all the somites. The somites then resegment to form the sclerotomes, and then each one of those is going to become a vertebra. And in fact, you can translate that model of spine development up to the craniovertebral junction. And I wrote this with Dakling Pang some years ago, and Dakling, you know, it was him that brought me to read something about some of the developmental biology and the mechanisms underlying segmentation. And they really are truly elegant, and it's definitely worth a read. Even if you read just the first part of this, I think you'll find it utterly amazing. I mean, the genes that control segmentation are part of something called the Hox code. And they're conserved over evolution. So they're the same in a Drosophila as they are in you and I. And they're a group of 39 genes spread over 4 chromosomes. And it's really the switching on and the activation of those that will determine what vertebra you have. So for example, here I've selected HOX1 here down to, what is it, HOXC5, yeah? And if you switch on this set of genes, then you'll get a C4 vertebra. If you actually switch on a different set, so down HOX, 8 down to HOX11, you'll get an L2 vertebra, for example. Now, of course, in the pathological realm, this can go wrong. And sometimes we get what's called an anterior homeotic transformation, when the identity of a vertebra assumes an identity that is actually higher than the one to which it's allocated. So a good example of this, if you like, is assimilation of C1. You can see here how C1 is being incorporated into the occiput. The thought here is that the genes that would have prescribed you to be a C1 are now incorporating the same ones that would be in the lower occiput, and so you get an occipitalized C1. That can be more dramatic. For example, in a case like this here, you can see almost the upper 3 or 4 vertebrae almost trying to become a clivus, if you like, and forming an identity that is anterior to what they should be. And of course, at the other end, you get something called, you can get a posterior homeotic transformation. For example, an L5 vertebrine sacralized is a good example of that. But it's important to remember, when you look at these abnormalities, it's very easy to infer a developmental abnormality, which actually is theoretical rather than real. For a long time, it was thought that the ossodontoideum was a congenital malformation, responsible then for instability. But in fact, if you actually look, this is a normal child here, and you can see some of the normal elements of the craniovertebral junction, which haven't yet fused just as yet. You can see here that these bits of the, in red there, I've got what would be the C1 sclerotome. Now, obviously, normally part of that segments, and the shaded red area normally becomes incorporated into C2 to form the base and the whole of the odontoid peg. And it used to be considered that actually it was because that red shaded area didn't join onto the rest of C2. That's what gave you your ossodontoideum. But in fact, the ossodontoideum, in reality, it's much smaller than would be predicted by that model. And in fact, what is most likely to happen, I think what we see mainly in clinical situation, in things like Down syndrome, for example, where the ossodontoideum is particularly common, is that it's a consequence of the instability, that in fact you get a fracture of the odontoid peg very early on due to the transverse ligament, and it's that gives rise to the ossodontoideum. This is a young lad that I looked after some years ago. He actually ended up with a scan at 3 years old. He'd got cerebral palsy with dystonia, and so had this terrible sort of chorioathetoid movement. But you can see that actually at this stage, when he was 3 years old, he had evidence of a normal odontoid there. But actually later on in life, he presented with a spastic quadriparesis. And you can see now what was a fairly normalish looking odontoid has actually developed into an ossodontoideum. And you can see the sort of inflammatory changes around that. So I think a good example of what might have previously been considered a congenital abnormality in reality is probably not that at all, but an acquired anomaly. And of course, you see this elsewhere. These are all cases of Down syndrome. And in Down syndrome, one of the classic features of Down syndrome is that these children tend to be quite hypermobile. Yeah, that's why they sublux their elbows and their kneecaps and so forth. But of course, because of the excess movement at C1, it's often difficult for the C1 to ossify in the normal way, and so you often get an incomplete ring in Down syndrome that I suspect reflects that difficulty for the C1 ring ever to complete, if you like, its ossification and form a solid ring. So, what we've looked at is, as I say, is that there are various different ways of looking at the craniovertebral junction. I've included this picture here. Many of you will know this. This is Las Minas. This is the Velázquez painting, thought to be one of the most important paintings of the last 300 or 400 years. And there's masses of PhDs and so forth written about this. But Velázquez was fascinated by dwarfs. You can see here an achondroplastic. People have tried to suggest that Marietta and others had also different bone dysplasias. But as I say, I think, so far we've looked at this from metabolic, genetic, developmental point of view. But as I already said, how does that really help us when it comes to seeing a child in the clinic and making a decision about what they need to do? Because for us as clinicians, as I say, it's difficult to know everything about each of one of these conditions. So how do you formulate a practical way of trying to understand these conditions? And what I have done over the past 10, 15 years or so, and rightly or wrongly, but it seems to have served me reasonably well, is to simplify this enormously. Because if you think about it, there's only three things that can possibly go wrong at the craniovertebral junction. You can either be unstable, you can either have deformity, or you can have compression of the neuraxis. And there are many of the conditions that we look at that have pure examples of this. So as I've already mentioned, Down syndrome. And Down syndrome, it's almost purely a problem of instability. Yes, as I've already shown, there may be secondary bone changes, but the primary problem is one of instability. When it comes to problems like, oh, sorry, I don't know if there's a, oops, I'm sorry about that. So deformity, you will also get problems, for example, in the segmentation anomalies I've already mentioned. You get acquired ones, such as atlantoaxial rotatory fixation, and you can get pure compression as a biomechanical consequence at the craniovertebral junction, for example, that we might see in achondroplasia. I'm sorry, the examples of those didn't come up, but I will be showing you some as we go along. And of course, in addition to getting pure examples of instability, deformity, or compression, those things can obviously occur in combination as well. So, for example, in Morquio disease, yes, we certainly get instability, but in addition, we have the problem of neuraxial compression, and it's that very dangerous combination that leads to the myelopathy. Here's another example where you get a combination, if you like, of skull-base deformity and compression. This is an example of a condition called Hadju-Cheney syndrome. It actually looks in many respects a bit like osteogenesis imperfecta, but you get this terrible deformity of the skull base associated with compression. So in terms of when it comes to the clinician interfacing with the radiologist and what investigation do you actually ask for, I think it's important to come back to this biomechanical interpretation of the craniovertebral junction, because the investigation you ask for very much depends on which question you're asking. So, for example, if you are looking at instability, then the main thing you're going to need is something like a flexion extension or dynamic view. And here, this is a case of Down syndrome, and you can see significant anterior subluxation at the craniovertebral junction, obviously mainly at C1, C2. Now, one of the important things we want to know is how severe is that? But I think one has to be a bit cautious here. As you know, there's a lot of literature about various measurements that you can make to assess the degree of atlantoaxial instability. Now, a lot of that data, in fact, the majority of that data comes from adult series, and it's very difficult to apply that to children. And in fact, I always have this bit of an aphorism, and I excuse you to all the radiologists listening to this, but I think, you know, I am always a bit wary of radiologists with rulers. And there are a number of situations that I could point to demonstrate that. One of them, this is a very old study now, but I think nonetheless it's very instructive. These 6 patients were all patients with Down syndrome. All of them had a flexion extension X-ray, which was, and the ADI, the atlantodental interval, was measured in millimeters. The reason why this study probably couldn't be repeated these days is what they did. Once they'd done the flexion extension X-ray, they repeated again on the same day. And you can see that actually on the subsequent X-ray, same child, same day, the results were very different. So for example, patient 1 was not subluxing in the morning, but was subluxing in the afternoon. Patient 2 was subluxing in the morning and not in the afternoon. So, you know, which one do you choose? Which one is the clinically relevant? So as I say, I think it's important to be very cautious. And I must admit, use less and less flexion extension X-rays these days. They can be useful, but you do have to interpret them with caution. One of the other of a dynamic or flexion extension X-ray is to really assess the degree of reducibility. Here is obviously a very, very dramatic case of atlantoaxial instability with almost complete spondyloptosis of C1 on C2. That's obviously bad, but in terms of your surgical planning, what you need to know is, can you reduce that? Yeah, and typically one will try to do this in extension, and you can see that even in extension, yeah, this child is still not reducing. So you're going to have to think of some other strategy, yeah, that you are going to be able to employ to realign the craniovertebral junction. What about deformity? So deformity can present at the craniovertebral junction in a variety of different ways. I've already mentioned the segmentation anomalies. There are also the laxity disorders, particularly things like Larson's syndrome. And there's also acquired ones, such as the atlantoaxial rotatory fixation. When we talk about the segmentation anomalies, so these are the ways in which I showed you that Hox code, where this has probably gone wrong in some way, maybe purely genetic, maybe have environmental epigenetic factors, as I already said. But we divide the segmentation anomalies into anomalies of form. You get complete disorganization of the structure here. Each of the vertebrae is formed very, very differently. And this is something that we see in the context of something called the oculoacoustic vertebral spectrum. These children often have things like a preauricular sinus, disorders of eye movement, and sometimes disorders of hearing as well. But then we also get anomalies of fusion. So this is when the actual vertebrae themselves, they're all there, but some of them are fused together so they don't segment in the normal way, although they retain their normal shape. And this, for example, would be seen in the classic Klippel-Feil syndrome, where you get this triad of a short neck, stiff neck, low posterior hairline, and you can see in this case a mild degree of torticollis as well. And anomalies of fusion, we also see them. I mean, this is a paper I wrote some years ago now, where we noted that actually in Apert syndrome, as you know, this is an FGFR abnormality, they get a very characteristic anomaly of fusion in their cervical spines. And the interesting thing is they don't occur randomly. Yeah, depending on whether you're an Apert or a Cruzon, they're quite specific, the levels that seem to be affected. And I think that probably goes back, there must be an influence there to the genetic patterning of segmentation. When it comes to the laxity disorders, these often have a classic radiological appearance. This is Larson's syndrome, for example, and they get this very typical reverse lordosis in the cervical spine. Can be very problematic because it often presents very early, and I'll demonstrate in a moment how we've managed cases of that in the past. Other examples would be Stickler's syndrome, Ehlers-Danlos syndrome, also where the problem is, yes, partly it's the bone, but also it's the sheer laxity of the associated connective tissues. Atlantoaxial rotatory fixation, clearly this is an acquired rather than congenital craniovertebral anomaly, but nonetheless one that is at very high risk of medico-legal problems because they're often picked up late, yeah, and they're often investigated incorrectly. These children, typically previously well, may have had an upper respiratory tract infection. Sometimes they've had an anesthetic for an ENT procedure, sometimes a minor injury, but then they develop this painful so-called cock-robin deformity. When it occurs after a upper respiratory tract infection, it's sometimes called Kudel's syndrome. And the problem here is that you basically have a rotationary abnormality, that the normal C1 ring is, I don't know if I can show you there, this is the rotation that's become problematic. This is clearly a normal, that's the normal movement there. But in a child, because their ligaments are intrinsically more lax than in an older person or an adult, they can get stuck into the rotated position. Now, one of the important things about investigating this condition is not to rely just on a static image. You need to perform the scan in left and right rotation. And I think this is a good example of a child who was investigated for atlantoaxial rotatory fixation. And if you just take this one image here, you can see that this image in isolation would be completely compatible with a diagnosis of atlantoaxial rotatory fixation. But the important thing is when the child looks to the other side, exactly the same thing happens. So this is just a demonstration of normal rotatory movement in a child who just had some muscular pain in the neck. This is not atlantoaxial rotatory fixation. What you need with your left and right rotation imaging is to confirm that the relative position of C1 and C2 is unchanged in the extremes. And you need that to affirm the diagnosis of atlantoaxial rotatory fixation. So as I say, in order to examine for deformity, in order to assess deformity, plain X-rays are pretty much a waste of time. You often need axial imaging, particularly if there's any form of rotatory deformity, and hence the use of fine-cut CT when you want to look at deformity. CT also very useful in terms of surgical planning because it will give you an idea of bone quality, bone size, particularly relevant in young children if you're thinking about having to instrument them. And clearly, if you want to evaluate the neuraxis, the effect of the neuraxis, obviously one needs MRI. Here's a good example, as I was saying earlier. Achondroplasia, I think, is quite a nice example of a situation where the problem is almost purely compressive. You don't have deformity here, and you don't have instability. It's very rare to have instability in achondroplasia. But what you do get is this very, very marked narrowing of the craniovertebral junction. It tends to occur in the first 2 or 3 years of life and can end up with this really quite severe damage to the spinal cord. And in fact, this can occur in children showing very, very few clinical signs. In fact, sometimes one of the first signs of this abnormality is sudden death. And that's increased, I think, people's awareness of this condition. And it's opened a big debate now on the role of screening these children for exactly this abnormality. And in fact, earlier this year, we published, over the years, I developed this sort of scoring system that I just tend to use in clinic. When do you select a child for surgery? And what we did is basically, I tend to look at simply the effect on the neuraxis. Is there preservation of the CSF spaces at the craniovertebral cervicomedullary junction? Or is there effacement of the spaces? Is there distortion of the spinal cord without signal change? Or do you have frank signal change? Now, because each of these children could be asymptomatic, at some point you've got to use some criteria to judge when you operate. And simply making numerical measurements, millimeter measurements, they're very difficult in children. Where do you define to take your measurements from? How do you make them age appropriate? How do you make them disease specific? So I think the advantage of this scoring system is it doesn't rely on any measurements, if you like. It just simply relies on the effect of the bony abnormality on the underlying neuraxis. And so, for example, days, we probably wouldn't operate on grades 1 and 2. We would always operate on grade 4. There's a bit of debate about whether grade 3 should be operated on, but I won't go into that. I guess one of the things to remember as well, that it's not just a neurosurgical issue. As I explained at the beginning, looking at this from a metabolic, a genetic perspective, many of these children have significant comorbidities, particularly in the mucopolysaccharidosis. In addition to their short stature, they often have problems with lung function because of their restricted chest. We now know that they can get an infiltrative form of cardiomyopathy. And so evaluating these children in a multidisciplinary way is absolutely essential. And really, is there always a surgical solution? Yeah, often not. Even though the problem may be structural, trying to reverse or change that can be extremely difficult. This is a child with an unusual bone dysplasia, gallbladder dysplasia. You can see at this stage, I think she was about 2 or 3 years old. You can see already that she's got significant platyspondyly, deformity at the cervicothoracic junction, possibly some early thoracolumbar change. But look what happens over time. These bones are getting worse and worse. The quality of the bone is deteriorating. Yeah. And you can see the overall shape of the spine is becoming more and more problematic. And you can see how the size of the head is now gradually becoming disproportionate to the rest of the body. It's almost as if these poor children, they outgrow their bodies. And of course, the effect on pulmonary function can be very dramatic. And sadly, there's very little that one can do from a surgical point of view here. And I think ultimately, this is going to rely on disease-modifying drugs to be able to try and improve the lot for these patients. And of course, in terms of evaluating these children, as I say, many other aspects of their care that need to be looked at, particularly lung function, as I've already said, cardiac in the case of the mucopolysaccharidoses. We may want to use things like DEXA scans to try and evaluate bone density and thus the suitability for instrumentation and the likelihood of getting bone fusions. And so what we've done over recent years at Great Ormond Street is have a sort of a very wide, quite comprehensive multidisciplinary team to evaluate these difficult children, to really assess their suitability for surgery. And after referral to a neurospine clinic, they come in and have a day assessment when they get seen by these various modalities. And then at a subsequent MDT review, the individual specialities basically then grade the children according to their suitability for surgery. You know, if it looks actually straightforward, yeah, risks are relatively low, they will get green. Yeah. Many of them, however, will have significant anesthetic, respiratory, cardiac abnormalities, and there it's important to raise caution, concerns about the relative benefits of surgery versus not. And of course, there were some who, after detailed evaluation, like the case of gallbladder I just showed you, are probably not appropriate to put through surgery because the advantages are simply not there. So I think in terms of formulating a strategy, what I've tried to demonstrate is, as I say, that actually of all these complicated things, you can just simplify it down to instability, deformity, and compression. That will help you decide on what the correct investigation is. It will then also help the surgeon to decide what is the appropriate operative strategy. Because if we have instability, clearly our main objective, our tactic, here is going to provide stability. If the problem is deformity, our tactic, has to include reduction of deformity as part of the operative technique. And of course, if there is compression of the neuraxis, then again, our tactic has to involve some form of decompression. And I think perhaps one of the most important aspects of the surgical tactics is achieving reduction when you have significant deformity. And I think this is particularly so in children more than adults. Reduction, reduction, reduction. You must try and optimize the alignment before then you do your decompression or your fusion. I showed you earlier, I think, this example of this child with Larson's syndrome. And so what we tried to do, this isn't actually her, but we used the same strategy to put in a halo and then over a few days gradually distract that halo to open up that kyphosis. And then that allowed us to put a rib graft into the front of the spine and realign. And this is 6-7 years later, and you can see how the alignment has been much improved and maintained, preserving the spinal canal there. This is perhaps a little less obvious, but nonetheless an important one to remember. This is you can see a mild degree of tonsillar ectopia here, but with quite almost a disproportionate but significant syrinx. One of the problems here is if you just treated this in a standard chiari-like way by doing a foramen magnum decompression, this would likely, it might work temporarily, but it would subsequently almost certainly fail because the underlying problem here is that actually this angle between the clivus and the spinal axis is too acute. The odontoid is slightly high relative to the C1 ring. And by decompressing at the back, you're just mechanically making things worse. Yes, you'll make some space, but what will happen is that is likely to progress over time. People sometimes, some of you may have heard of the so-called PBC2 line, and it's a means of, if you like, assessing degrees of basilar impression. And I incorporate it here, not as I told you already, because I'm a big fan of doing angles and measurements all the time. But nonetheless, here you can see what we've done is we've distracted at the time of decompression and fixation to try and improve that effective basilar impression as part of the operative strategy. So now we've we've reduced the deformity, yeah, we've decompressed, and we have fixed. This is a more dramatic example, as you can see here. Here, the odontoid definitely rising. You can see a severe form of platybasia here, but again, a very acute clivo-axial angle. But again, the tactic, the surgical tactic was the same, to actually put the child into a halo orthosis, distract them to improve that alignment, so we make the clivo-axial angle much, much better, yeah, and at that point then we know we've improved the degree of basilar impression, and then we can go ahead and instrument and fix. Sometimes, of course, it's not quite as complex as that, and a decompression supplemented by a bone graft fusion may be all that one needs to do. Now, clearly, if, as I said before, when we sometimes use dynamic imaging to find if the problem is reducible. And I think one of the problems, and I've seen this a lot in Down syndrome children who have severe atlantoaxial fixation, atlanteal subluxation, they have surgery, but they have surgery. For the surgeon, they always like to operate in the flexed position. But of course, that's a disaster for the child. And this is an example of a child who had surgery elsewhere. They were trying to fuse at the back, but as you can see, they've been fixed in deformity. So now we're in the worst of all worlds. We've got a problem of posterior as well as anterior impression. And of course, because there's surgery at the back now, there's very little that one can do about that. And your option here now is to actually decompress anteriorly, which one would do through a transoral approach to remove all that ventral compression. And then that allows you to revise the posterior metalwork and fix the child to keep them safe for the future. And again, I know this is maybe not many surgeons are listening to this, but just to show you, I guess, some of the tactics that we use for stabilization. The gold standard is probably instrumentation. And here you can see a typical occipital plate secured to C2 with these screws. And this provides an unquestionable, the gold standard of fixation. But of course, in very young children, in children with bone dysplasia, their bones may simply not be possible for that. And so one of the other techniques that we will commonly use is take autologous bone. And in fact, this is calvarium, it's skull bone that's been taken, full thickness, yeah, and wired onto the back of the skull. And you can see that that can give you a very, very nice fusion. But that doesn't mean the child has to be immobilized in a halo for a period of time whilst you're getting that, whilst you're waiting for that fusion to occur. So I'm sorry if that was a bit of a whirlwind travel through the craniovertebral junction, and I appreciate that I probably glossed over a number of conditions, but obviously time precludes one in a lot of detail. But I hope I've demonstrated that, yes, the spectrum of CVJ pathologies in children is enormous. It's incredibly wide, and I think it's almost impossible for all of us to know. And I think as a result of that, just simply diagnosing these abnormalities, giving them a name, or even understanding their etiology doesn't necessarily help us. It gives us some help because it can give an idea of prognosis. But I think a biomechanical approach is a much, much better place to start. What is this condition? What are the likely problems I'm facing here? Is it instability, deformity, or compression? Because that will tell me what should be my strategy for investigation. And it will certainly then inform me as a surgeon as to what is my best tactic to deal with the problem. And I guess a final word of caution that what is possible is not necessarily, or what is always necessary. I mean, some of these children, surgery is not the be all and end all or the solution to their problems. And for some of them, sadly, non-operative intervention and palliative care may be more appropriate. And I'm leaving you with a picture on the right there. This was a find of my son and I on a holiday some years ago. We found a dead dolphin. And I remember from one of my old neuroradiology teachers that the dolphin has a very interesting craniovertebral junction. They lack an odontoid peg. They have a ball and socket joint at their craniovertebral junction. So that the dolphin, he can say no, but he can't say yes. Anyway, thank you very much indeed, and I hope that's provided of some interest.
Thank you so much, Dominic. This was really an amazing talk. I really learned a lot from it, and amazing picture at the end as well. We do have two questions so far, so I might just get started with the first one coming from Kish that he has already posted also on YouTube. And this is regarding the atlantoaxial rotatory fixation and the measurements. You kind of started on this explaining that as well, but maybe you can focus on this one. And do you think it makes sense to measure this or not?
Yeah, thanks, Uli, and thanks, Kish. And I think what Kish is largely alluding to here, there's a very nice pair of publications actually by Dakling Pang in neurosurgery from a few years ago. And what he shows in a very mathematical way is if you like, a means of trying to develop your tactic, if you like, based on radiological measurements. He basically plots a number of, then give you an idea as to what tactic you should pursue. It's very elegant. It's very well thought out. I have to say, from a practical point of view, I question its utility in a routine basis. Most of the times, the clinical presentation is quite clear. These children present with an obvious torticollis posture. You then do your radiology and you show that no matter what you do, that C1 is forward with respect to C2. And those children need to be fairly urgently treated, because what happens if you don't treat them is that they fuse in that position. And so you get children that end up with a permanent, very significant cosmetic deformity. Now, again, some of you will know that there's a fielding classification of rotatory fixation. Again, from my point of view, I've never found that really influences enormously what I do. Basically, you go back to first principles. You have a deformity here, so you have to reduce it. So step one is to reduce the deformity, which sometimes that's all you need. And if you get these children early, they can sometimes get a reduction under anesthetic, and you put them in a collar for a couple of weeks and it's job done. If they are sublux again, then what we would do is repeat the imaging to confirm that it's gone off, get them back into position, but then fuse them in that position so that it can't happen again. So, I'm not completely dismissing the Pang measurement. As I say, it's a very elegant paper. It's well worth a read. But from a practical point of view, I'm not sure it always, I don't think it's required on a regular basis is the answer.
Thank you very much. We also have a lot of comments on YouTube where everyone is saying very informative and very elegant talk, and also very clinical, and everyone is thanking you very much, just in case.
Oh, thank you. That's very kind. Thank you.
I would also have one more question. We kind of discussed this a little bit when you were in the reading room, and we started thinking of you doing this talk, and that is with respect to segmentation anomalies, where
sorry, you want anomalies?
Segmentation anomalies.
Yes.
Where initially when I came to GOSH and I had not seen a lot of those before, I tried to describe every single detail and looked at every vertebra, but I pretty much gave up pretty soon because it's sometimes impossible to do. Yeah. And you had also said, like you nicely illustrated also, that the simplified approach with the stability, deformity, and compression is actually what you're looking for. So would that also be what you are looking for in a radiology report? Or do you think this is more something you would then assess based on our report and what you want us to describe in these difficult anomalies?
Yeah. No, absolutely, Uli. And as I said in the talk, I mean, some of them, and I think I showed you one or two illustrations there of these really bizarre abnormalities of vertebral segmentation, that one with the Golden House syndrome. And they're, describing whether there's a bit of C1 or a bit of a C2. Sometimes you see reports going into 2 and 3 pages that I don't think are terribly helpful. I think, it is important then to go back to the, is there significant deformity, as you say, and you can normally assess that, and particularly with 3D recons in the CT, I think can be particularly helpful in that respect. Obviously, we do want to know if there's an effect on the neuraxis. Interestingly, in the segmentation anomalies, the Klippel file type, paradoxically, they often have a slightly wider spinal canal than normal. And so compression of the neuraxis is relatively unusual in these children. I think the problem for them often happens later on in life when they start to get adjacent segment disease. So the discs that are healthy and retained, they start to wear out and cause problems earlier on. So again, I think it's a question of coming back to basic principles. What do we really know? And certainly in the clinic, when I see a kid with a cervical segmentation anomaly, often the families are quite eager to have some surgery, but actually if you think about it, what would the surgery do? The option you have is to perhaps get them back into a normal position and then fuse them. But of course, then they lose all movement. So, and as I say, many of these, they stay very stable over time. I think there is a role in radiology of documenting change over time, because as I say, you do want to pick up those adjacent segment disease, but I wouldn't get too hung up on, identifying every particular measurement.
Thanks so much. We have a couple more questions if you still have time. That would be nice. There is Shianas who was asking, do you do dynamic CT on all your AARF patients?
Yes, is the bottom line, because I think for the reasons I tried to show in the talk, you should at least attempt it. Now, sometimes in young children who are in pain, you may not get great images. I totally accept that. But I think you do have an obligation to at least attempt to do the test. And typically with a child who presents with acute torticollis with a presumed atlantoaxial rotatory fixation, our first thing we would do, we will give them analgesia, start them on some muscle relaxant. And then the first CT, you do it in the position of deformity, yeah. And then once you've got that, you see if they can move to the other side to repeat your next. So I think yes, you should at least attempt it, because I think it's one of the, if you like it, it's one of the diagnostic criteria that allow you then to make a decision on your next step, which is going to be typically some form of intervention, reduction or fixation.
Thanks. One more question from Nihal. Dr. Dominic, is there a role for dynamic vascular imaging along with dynamic plane imaging for instabilities?
Yeah, it's a good question, that. And I think there is, some of you will have heard of this concept of Ehlers-Danlos type 3. It's a very controversial condition that people are now starting to do flexion extension MRIs for example. And I think one of the problems in some of those investigations is the lack of normative data. I think, again, sometimes I've seen MRI reports from flexion extension MRIs with massive amounts of angles and everything written. I mean, you have to remember that by definition, the craniovertebral junction is a mobile structure. And I showed you, even when you look at plain X-rays, how even on the same day, a measurement can be different in the morning and it can be in the afternoon. If you multiply that into 3 or 4 dimensions, by doing 3D imaging and so forth and measurements, I think it's very likely you will end up with a similar problem. So, yes, occasionally I think there are roles for vascular imaging. I showed you a CTA, I think, during that of an achondroplasia patient. Sometimes it is useful to know where the vertebral artery is. Do you have a dominant or a non-dominant vertebral artery clear near where you're going to put a screw? But I wouldn't say it was a routine investigation.
Thanks so much. Nihal also was asking for imaging protocols and treatment for children with Bow-Hunter syndrome. Any ideas?
Sorry, for Hunters?
Bow-Hunter syndrome.
I'm sorry, I did the syndrome, but
Bow-Hunter syndrome.
I'm not sure I know what that one is.
Okay, so we'll skip this one. Next one is, do you feel imaging in dural venous sinuses adds anything to chiari 1 imaging? And would you advise doing it routinely? This is from Debs from Belfast.
Yeah, I mean, the answer is no. We don't typically do imaging of the venous sinuses as part of a chiari workup. Now, I suppose with one caveat, and that's that, I think it is well recognized now that you can get a chiari secondary. I mean, I think it's well recognized, for example, in vein of Galen malformation, where pre-treatment you often get this engorged cerebellum because of the venous distension, the cerebellar tonsils poke down, and that may reverse on treatment of the vein of Galen malformation. But that's obviously a very specific circumstance. So, as I say, no, I wouldn't routinely say, that I would use venous imaging in chiari, but I think the underlying thesis is that, I mean, again, it's moving off topic now, but I think certainly at Great Ormond Street, we very much moved over recent years to move away from thinking of chiari as a disease. We tend to think it as a consequence of something else. Yeah, and that's something else. It may be a craniovertebral malformation, it may be venous hypertension, it may be CSF circulation abnormality. So I think it's a good thing to remember when you're investigating chiari. Always ask the question, why has this kid got a chiari? Because it may be a secondary problem, not a primary one.
All right, thanks so much. This was all the questions. So
okay.
Thank you again, Dominic, for joining us today. This was an amazing presentation, and I hope to see you all again soon. Have a good afternoon and have a good weekend. Bye.
Thank you very much indeed, Uli. Take care, everyone. Thank you for your attendance. It's much appreciated. Bye-bye for now.